Okay. So hi, evening friends, evening everybody, bache, evening everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS PAMC, MD Pathology, Resident Hematology, AIMS Delhi. And let us start with our most important topics for the pathology INI exam. Now, before I even go further, microbiology plus pathology we discussed it in our micro session also. Hi, evening Libra, evening Adya, evening everybody bache. And I guess we'll get used to each other. I always give 2-3 minutes. I mean, I get late, so that's okay. So evening Tanvi, Mona, everybody bache, everybody. So let's start. We discussed the same thing in our microbiology session also. Path plus micro constitutes approximately 24 to 25 questions in your NEET PG as well as the INI exam for the dental subjects. I am saying so because it has undue weightage. I do not know why, but past 2 years, thanks, Sanvi. Seriously, thanks, and it is nice to see all of you also. So, past 2 years, this is the trend that we are seeing. So, let us quickly have a look at the pathology topics. I know some of you will be new students, that is, you would not have attended my full course and stuff. So, if you find this slightly tougher, absolutely not to worry. We have a full live class coming up very soon in our app. So, we will be covering all these topics in detail there also. This is a quick revision for the students who have attended the live classes. So let us start with our first image. Diagnosis. Keep on telling me the answers. What do we see here? Dekho, the minute I see this, I know it is pink and blue. That is, it is H&D stain. Hematoxylin and eosin stain. Hematoxylin is blue and it stains the nucleus. Eosin. EO is pink and it stains cytoplasm. This is H&D stain, showing the presence of RBCs in the lumen. For Aisha Bache, yes, exclusive TND and grant tests are available for INI. I'll ask the team to connect with you, dear. You can send a DM on Telegram group also, and I'll assign a team member. Not to worry. Now, the minute I see this image, we are able to make out that this is a luminal structure with RBCs in it. That is, it's a blood vessel. The vessel wall is broken. Disintegration of vessel wall with fibrin-like material. That is, this is fibrinoid necrosis. This is fibrinoid necrosis. The diseases associated with fibrinoid necrosis being which vasculitis? PAN, polyarteritis nodosa. Malignant graft rejection, malignant hypertension. It is not benign hypertension, it is malignant hypertension. Graft rejection. Graft rejection. I took the graft, my body rejected it. Graft rejection, which it is of 3 types: hyperacute, acute, chronic. Graft rejection, hyperacute type. See, fibrinoid necrosis, it is the most aggressive pattern of necrosis. So it is seen in malignant hypertension. Graft rejection, hyperacute type. Which vasculitis? PAN. Next is RHD, rheumatic heart disease, and SLE. Hi, evening, Vishnu, Kanishka, everybody, bache. So this was our first slide. You have not missed out on anything. These are the diseases associated with fibrinoid necrosis. Next question. Diagnosis. Which body? Bodies are important. I mean, no double meanings to this. Which body do you see here? Dekho, the minute we see the presence of this, these are large cells with abundant granular cytoplasm with presence of a central nucleus. That is, all of these cells, these are the hepatocytes. These are hepatocytes, making it as liver. Which is the abnormal cell in this? This hepatocyte. It is a contracted granular hepatocyte. It is shrunken in size. We have a clear white space around it. That is apoptosis of hepatocytes, called as Councilman bodies. Which is a feature of acute hepatitis. So let us quickly make a list of bodies seen in pathology. Microbiology, the list of bodies we have already made in our micro session. Councilman bodies, acute hepatitis. You know that. Next is Crayola bodies. Keep on telling me the diagnosis. Crayola bodies, which are seen in asthma. Asthma, remember, microscopically shows the presence of 3 Cs: Kirschmann spirals, Charcot-Leyden crystals, and Crayola bodies. So Crayola bodies, asthma. Next, asteroid bodies. Asteroid and Schumann bodies. Asteroid bodies and Schumann bodies. Answer, bache. It is seen in non-caseating granulomas with bilateral hilar lymphadenopathy. Diagnosis? देखो, caseating granulomas is TB. Non-caseating granulomas with bilateral hilar lymphadenopathy? Sarcoidosis. Sarcoidosis. Next, Russell bodies and Dutcher bodies. Russell and Dutcher bodies. They are seen in elderly with low back pain. Which blood cancer? Which you keep on telling me the answers side by side. Elderly with low back pain, multiple myeloma. Extremely important. So Russell and Dutcher bodies, they are associated with multiple myeloma. HP bodies, Henderson-Peterson bodies, molluscum contagiosum, recent INI PYQ. Negri bodies, Negri black dog bites, rabies. Next, Howell-Jolly bodies. Next is Howell-Jolly bodies. Howell-Jolly bodies seen in megaloblastic anemia. Seen in megaloblastic anemia, post-splenectomy, and thalassemia. Megaloblastic anemia, post-splenectomy and thalassemia. So this was a list of bodies. Hi, evening, Srishti, evening, everybody, bache. So these were the list of bodies which we are commonly see in pathology. Next point. So coming back to this was apoptosis of hepatocytes, that is Councilman bodies seen in acute hepatitis. Next point. Now have a look at this image. Examiner just told you that this is gel electrophoresis and column A is asked. Gel electrophoresis, column A is asked. Your options are normal DNA, normal RNA, necrosis, या apoptosis. Answer, bache. How will you go about in this? I know, Srishti, all of and they are extremely happy with you कि they had oral path. कोई बात नहीं. Pathology will also come up and then we'll see. But coming back, answer. Column A is, देखो, now you're not going to distract us. This is a high yield session, so no gossiping. This 40-45 minutes we'll study with attention. I know, B, this is dinner time also, but still. But your column A is, देखो, what do we see? Let us first start with column C. Column C, this is normal DNA. How do I know that? Because it is a single band. It is a single discrete band which is close to the point of application of the sample. This is the point of application of the sample. Sample was put here. It is heavy, so it migrated less, normal DNA. Column A, which you are able to see a diffuse smearing pattern. DNA is randomly getting degraded and forming smaller fragments. That is, this is diffuse smearing. This is diffuse smearing pattern because of random degradation of DNA, which is a feature of necrosis. Versus column B, it is programmed cell death. The DNA is getting fragmented at specific sites by the action of endonucleases, in turn giving it the classical stepladder pattern. Vishnu totally agreed here. In turn giving it stepladder pattern in column B, that is apoptosis. Because endonucleases, they cut DNA at particular sites. It is programmed cell death now. So the DNA fragments that will be made will be of a particular size only. So they will go to a particular site in gel electrophoresis, that is the stepladder pattern. Column C was normal DNA versus D, that is normal RNA. We see two bands, 28S and 14S. We see two bands slightly away from the point of origin. This is gel electrophoresis. Again, an important concept. Now, when we talk of necrosis versus apoptosis, just listen to this. Apoptosis, you very well know, is programmed. Which proteins play a role in apoptosis? Caspases. It is programmed caspase dependent cell death. Programmed caspase dependent cell death. It is not associated with inflammation. If you know this, you will know everything. Leakage of cellular contents. leakage of cellular contents is not seen. Obviously, if inflammation is not taking place, that means the leakage of cell contents is not seen. That means plasma membrane integrity. Plasma membrane integrity is maintained. Versus necrosis, which is associated with inflammation. So leakage of cellular contents is seen and plasma membrane integrity is lost. All these 3 points are the same. If inflammation is taking place, leakage of cell contents will be seen and plasma membrane integrity will be lost. That is necrosis. It is only pathological. Versus apoptosis, which is both physiological and pathological. And lastly, extremely important, apoptosis is not associated with cellular swelling. It is not associated with cellular swelling. Recent NEET PG MBBS segment PYQ, easy PYQs are repeated in our paper also. So this was the master table of necrosis versus apoptosis. Another important point that is asked in apoptosis are the caspases associated. So we can divide apoptosis into 2 pathways, that is an intrinsic or the mitochondrial versus extrinsic, that is the Fas ligand or the death receptor pathway. Fas ligand or the death receptor pathway. These are the 2 pathways of apoptosis. Now caspases, they are of 2 types, that is initiator versus executioner caspases. Initiator versus executioner caspase. The initiator caspase of intrinsic pathway is caspase 9 versus extrinsic, which is caspase 8 and 10. Dekho, easy to remember. I am sitting at my home. 2 friends, 8 and 10, came from outside. It is a party at my place, so I will sit in the center. Caspase 9 is the initiator caspase of intrinsic pathway. 8 and 10, 2 friends came from outside. Now in the party, everybody will have the same food. So executioner caspases are caspase 3 and 6. Executioner are caspase 3 and 6. These are the caspases associated. Which is the main initiator caspase of extrinsic pathway? Caspase 8. The first one, dekho, we always remember our first love now. So initiator caspase of extrinsic pathway, caspase 8. Initiator caspase, the executioner caspase, main being caspase 3. So the first ones are always the main ones. This was with respect to apoptosis, and on gel electrophoresis, this is what it looks like. Everybody, please give me a thumbs up or a heart or like the video if all of you are comfortable with all the points that we have covered till now. I'm saying so because I know I'm going slightly faster, and for majority of us it is the first time that you are studying pathology with me. So please do give me a thumbs up. In case you want me to go slightly slower, do not hesitate to say that. Next point. This gets us to our next commonly asked topic in INI exam, that is calcifications. Calcifications, they are of 2 types, dystrophic versus metastatic. Dekho, D say dystrophic, D say dead or damaged tissue. So dystrophic calcification is seen in dead or damaged tissue versus metastatic, which is seen in normal tissues. The most common site being lungs. Where in the normal tissue? Most common site being lungs, followed by stomach and kidney. So 3 main sites: lungs, stomach में gastric mucosa, kidney में renal tubules. First class. Next important point, serum calcium. Calcium levels in metastatic calcification are high. देखो बच्चे, very obvious. Calcium in the blood was high. That is why it goes and gets deposited in normal tissue. Calcium was high, so it goes and gets deposited in normal tissue. Versus dystrophic calcification, where serum calcium is normal, but it goes and gets deposited in dead or damaged tissue. This is a very important point. Very, very important. Serum calcium. In metastatic calcification, calcium is high, so it goes and gets deposited in normal tissues, versus dystrophic, where calcium is normal. Next, examples associated. Dystrophic calcification. Dystrophic calcification, it is seen in RHD, rheumatic heart disease, atherosclerosis, RHD, atherosclerosis. And I want you to tell me, what is calcification associated with tumors called as? Semoma bodies. Extremely important. Calcification associated with tumors, that is called as semoma bodies. Semoma bodies. Which are the tumors associated with calcifications of semoma bodies? Papillary RCC, that is papillary renal cell carcinoma, papillary RCC. Which ovarian tumor? Serous ovarian tumors. Serous ovarian tumors. Next, which brain tumor? Meningioma. Meningioma. Prolactinoma. Meningioma. Prolactinoma. Prolactinoma. Mesothelioma. Meningioma. Prolactinoma. Prolactinoma. Mesothelioma. Mesothelioma. And which thyroid malignancy? PTC. Papillary thyroid carcinoma. PTC. PTC. Papillary thyroid carcinoma. These are the tumors associated with semoma bodies. Follicular knee, Vishnu, follicular knee, PTC. Please have a good list. These are the tumors with semoma bodies. Guys, just give me 1 sec. Okay, so coming back, there are some calls which even I cannot afford to miss. But coming back, these are the tumors with semoma bodies. So suppose you had a question that is 18-year female presenting to OPD with dural mass, complains of severe throbbing headache. MRI shows the presence of dural thickening, histopathology of which shows whirling and calcifications. This is the exact language of the question, which is the most probable diagnosis. Suppose you get such a question. We do not expect you to know about CNS tumors, but the key word in that question was dural mass and calcifications. So which is the brain tumor associated with calcifications? Meningioma. So you can always be given such 2 to 3 line history-based questions with respect to medicine. So it was actually not a question from CNS tumors, it was a question from general pathology, meningioma. Next, versus metastatic calcification where serum calcium is high. Serum calcium is elevated. The examples of which are, which hormone is needed for elevating calcium? Parathyroid hormone. Hyperparathyroidism. It is associated with hyperparathyroidism. Next, I want you to tell me this. Plasma cell malignancy. It has increased number of plasma cells. Increased plasma cells with any one CRAF features. Plasma cells with CRAF features. What is the name of the blood cancer? Multiple myeloma. Perfect. It is called as multiple myeloma. Multiple myeloma, which it is a malignancy of plasma cells. There are increased number of plasma cells with any one CRAF feature. CRAF is calcium is increased. R, renal insufficiency. Renal insufficiency. A, anemia. B, bone lytic lesions. CRAF features. Calcium is increased. Renal insufficiency. Anemia. Bone lytic lesions. Because calcium was increased, it was metastatic calcification. Multiple myeloma. Akshita, bang on right. Which immunoglobulin? IgG. On protein electrophoresis, it shows the presence of M-band. M-band, that is monoclonal band on protein electrophoresis. All these are the high yield points with respect to multiple myeloma. And lastly, metastatic calcification, that is calcium is high. In which granulomatous lung disorder? Remember that non-caseating granulomas with bilateral hilar lymphadenopathy? Sarcoidosis. Sarcoidosis, it shows increased serum calcium because of secretion of vitamin D3 from granulomas. Sarcoidosis, which is the granulomas. It has non-caseating granulomas. Granulomas secrete vitamin D3. They secrete vitamin D3, so serum calcium is increased. First class. This was our next important topic for our INI segment, that is calcifications, dystrophic versus metastatic. अच्छा, मुझे stains भी बता दो. Most commonly used stain for calcium? Calcium. We can divide the stains into most common versus most specific. देखो बच्चे, easy to remember. Calcium को कोसा. Most common stain, von कोसा. But the most specific, actually the TB नहीं बचे, sarcoidosis था ना, it was non-caseating element, sarcoidosis. Most specific stain for calcium being alized and redis. Easy to remember, it is useful for staining zara sa calcium also. So most specific, alized and redis. We'll have a look at stains in just 2 minutes. So this was about calcifications. Next topic. Next, this gets us to inflammation. You very well know the steps of inflammation. That is, inflammation, it is first associated with transient vasoconstriction. That is transient in nature, it's for a short time only, followed by vasodilation. The blood vessel dilates. So WBCs come to the margin. Margination, rolling. They start rolling on the vessel like a football. Rolling, adhesion. Permanent attachment. Then they come out of the vessel wall, called as diapedesis. Diapedesis, it is mediated by CD31 or PCAM. After coming out, it has to go to the site of inflammation. Chemotaxis. After reaching the site of inflammation, there is recognition of the microbe. It has to recognize that this is the microbe. Recognition of the microbe, followed by eating it up. Phagocytosis, phagolysosome formation. Phagolysosome formation. This phagocytosed material binds with the lysosome. Phagolysosome formation in turn leading to killing. These are the steps of inflammation. We'll have a look at the major points associated. Rolling, adhesion, chemotaxis, opsonization. These are the 4 points from which you always get a question. Starting with rolling. WBC is rolling on the vessel. It's like a football rolling. So WBC receptor binds to an endothelial receptor. Same thing is true with adhesion. A WBC receptor will bind to an endothelial receptor. So for rolling, the name of the WBC receptor is sialyl Lewis X glycoprotein. The name of the WBC receptor is sialyl Lewis X glycoprotein, which binds to selectins present on endothelial cells. कुछ भी नहीं है, this is nothing. Like all of us have names. I'm Sushant, you guys are Hansika, KK, Akshita, Vishnu, Adya, so on. This is the name of the WBC receptor. Sialyl Lewis X glycoprotein, present on WBCs, binds to selectins on endothelial cells, which leads to permanent attachment, that is adhesion, which is due to integrins present on WBCs binding to integrin ligands on endothelial cells. These are the names of receptors for rolling and adhesion. This is extremely important because we have 2 diseases. LAD1, leukocyte adhesion defect 1, LAD1, which is a defect in adhesion, versus LAD2, leukocyte adhesion defect 2, LAD2, which is a defect in rolling. बच्चे opposite है. Rolling occurs before adhesion, but LAD1 is a defect in adhesion, LAD2 is a defect in rolling. In both of these, the problem is in WBC receptor. So LAD1 occurs because of a defect in integrins. LAD2 occurs because of a defect in sialyl Lewis X glycoprotein. Simple table. There are 2 diseases associated. Both LAD1 and LAD2 were autosomal recessive in nature. Next point. Now rolling and adhesion has taken place, followed by diapedesis. They come out. Diapedesis is mediated by CD31 or PCAM. It occurs due to CD31 or platelet endothelial cell adhesion molecule, CD31 or PCAM, followed by chemotaxis. I want you to tell me the chemotactic agents. Chemotaxis, that is migration of leukocytes to the site of inflammation. Exogenous chemotactic agent are bacterial or viral products. Wherever bacteria or virus is present, WBC will go there. What about endogenous chemotactic agents? Which complement factor? C3A, 3B, 5A, 5B. You always get a question from chemotactic agents, opsonization agents, and the cytokines associated. So we'll make a list abhi. Which complement protein serves as chemotactic agent? C3A, 3B, 5A, 5B. C5A, C5A. Others are leukotriene B4, interleukin 1, interleukin 8, and TNF alpha, tumor necrosis factor alpha. Most potent, Akshita, bang on right here. Totally agreed. I know there is some lag between me asking the question and you answering. Agreed. Adya is very quiet. Is she there in the session? You're dead tired and left. I'm asking you because I've been told ki you're good. Next, Nikesh, you are very right that most potent chemotactic agent, leukotriene B4, LTB4. Complement protein which is most potent, C5. Most potent pyrogen, that is it causes fever, pyrogen, interleukin 1, followed by interleukin 6, followed by PGE2, prostaglandin E2. Please put a star. PGE2 was recent MBBS segment PYQ, so it can be asked from us. Second most potent pyrogen, interleukin 6, followed by prostaglandin E2. Interleukin 8 plays a role in ARDS, acute respiratory distress syndrome. But if COVID-19 ARDS is asked, then the main cytokine associated being interleukin 6, increased levels of which are poor prognosis in COVID-19. But we do not expect a question on COVID to be asked now. Thankfully, the pandemic is over. Next, TNF alpha plays a major role in sepsis, tumor necrosis factor alpha. TNF alpha plays a major role in sepsis. So these are the chemotactic agents. After reaching the site of inflammation, the next step is recognition of the microbe. So which are the opsonization agents? Opsonization agents, they are the substances which make the bacteria tasty for phagocytosis. They make the bacteria tasty. So which are the opsonization agents? Which complement protein? 3A, 3B, 5A, 5B? C3B. Please note, C5A is a chemotactic agent, C3B opsonization agent. Other opsonization agents are mannose. Bacterial cell wall, it has mannose on it. It makes the bacteria tasty for phagocytosis. Mannose. FC fragment of IgG. Dekho, antibody. Antibody has two parts, fragment antigen binding and FC end. WBCs have FC receptors. So what is making the antigen tasty for phagocytosis? FC fragment of IgG, because it is the FC end of IgG which goes and binds to WBC receptor. So what is making it tasty? FC fragment of IgG. CRP, C-reactive protein, CRP and fibrinogen. CRP and fibrinogen. These are the opsonization agents. These are the substances which make the bacteria tasty. C3b, mannose. Bacterial cell wall had mannose. FC fragment of IgG, CRP and fibrinogen. These are the opsonization agents. So we have seen the master table of chemotactic agents followed by opsonization agents. So now WBC knows that this is the microbe. It will engulf it up, followed by kill it. These are the steps of inflammation. So this gets us to our next important topic, that is the diseases associated. Very, very important again. We have seen LED1 is a defect in addition. LED2 is a defect in rolling. Both LED1 and LED2 are autosomal recessive. LED1, it is a defect in addition because of a defect in, which was the WBC receptor for addiction? Integrins. So it is a defect in beta 2 integrins. It occurs due to a defect in beta 2 integrins. So clinically, it is associated with increased risk of infections. Obviously, if addition is not taking place properly, the risk of infections increase. Increased risk of infections with, put a star, with delayed separation. with delayed separation of umbilical cord stump. Delayed separation of umbilical cord stump. Very, very important. See, this is how a clinical history based question is also given to you. Suppose you have a question in which it is asked, a 7-year child presenting to OPD with 3 episodes of strep pneumoniae last year. Presenting to OPD with 3 episodes of strep pneumoniae last year. Now coming to OPD with otitis media. Examiner will not write repeated infections. He gave you a history of 3 episodes of strep pneumoniae last year, now presenting with otitis media. Further workup of the patient shows or elicits a history of delayed separation of umbilical cord stump. It shows delayed separation of umbilical cord stump. Diagnosis, LAD1. Leukocyte addition defect 1. LAD1, which is a defect in addition. Same history shows mental retardation with Bombay phenotype. Increased risk of infections with mental retardation and Bombay phenotype. Bombay phenotype, it is a rare blood group. This history, mental retardation with Bombay phenotype, is associated with LAD2, leukocyte addition defect 2. LAD2, which is a defect in rolling. Same history with neutropenia. Neutrophils are reduced in number. Neutropenia and giant granules in neutrophils. Neutrophils are reduced in number along with the presence of giant granules. In neutrophils. Diagnosis. I want you to tell me this. I'll give you 10 seconds to tell me this. देखो बच्चे, why will there be giant granules in neutrophils? Neutrophils, it phagocytosed the toxic matter, but it was not able to kill it. That is, it is a defect in phagolysosome formation. It is a defect in phagolysosome formation. Phagocytosis occurred, but it was not able to kill the organism. Defect in phagolysosome formation. What is the defect in phagolysosome formation called as? Think of it yourself कि तुमने किसी से पंगा लिया, thinking I will beat that person, but you were not able to beat him, so you will get beaten up. So same thing is happening with neutrophils also. Neutrophils phagocytosed the toxic matter. Phagocytosis occurred, but phagolysosome did not form. So killing did not take place. So it is associated with neutropenia. Neutrophils got killed, and that phagocytosed matter is present in neutrophil as such. That is neutropenia with giant granules in neutrophils. Akshita, very right here. Called as Shidiak-Higashi syndrome. Shidiak-Higashi syndrome. Totally agreed. And lastly, if you have a history of a child with neonatal seizures due to hypocalcemia. Calcium is low, which can present as seizures. Hypocalcemia and thymic hypoplasia. Thymus is underdeveloped. The minute we talk of thymic hypoplasia with neonatal seizures, diagnosis, thymus was underdeveloped with CVS abnormalities and neonatal seizures. I can add CVS abnormalities also to this list. It was this time's FMG segment PYQ. So again, can very comfortably be asked in our paper also. Which is the topics in different papers, they always remain the same only. So neonatal seizures, thymic hypoplasia and CVS abnormalities, it is a case of Diapedesis syndrome. It is a case of Diapedesis syndrome. Diapedesis syndrome, remember chromosome 22q11 deletion. It is the one with chromosome 22q11. Chromosome 22q11 deletion. Diapedesis syndrome. So this was increased risk of infections. अच्छा वैसे before I go further, tell me this very truthfully. अपना अभी क्या हाल चल रहा है? In the sense कि I know medical subjects are always on the slightly tougher side. We guys are much more comfortable with dental subjects. Majority of us usually think कि medical subjects the weightage will be less, and that was the scene earlier, I agree to that hardly 10-15% questions were asked from medical subjects. Majority were dental. But which the trend is changing. Medical subjects are being asked in our INI exam also. So we have to give proper weightage to medical subjects. I'm saying so because dental subjects will get you to a level. If you are not good in dental subjects, you are not going to be able to compete with others. There's no doubt about it. So हमें dental subjects तो देखो पता होने ही चाहिए. They will get us to a level. But what will get us the top ranks are actually the medical subjects. So before I go to the next topic, अपना क्या हाल चाल है, कैसा चल रहा है? मतलब are we able to study कि हाँ sir everything is okay, I am working only, I am working and studying types, it's okay. Somehow life is going on and I am hopeful. Next option 2 is कि yes I am studying but it is plus minus, पता नहीं चल रहा in which direction I am going. Third option कि I am not able to take out as much time as I want for studies. मतलब which category are we in at present? Very curious which है. Firstly this is my question, and secondly, how many of us are preparing for the INI exam? मतलब are we preparing for this INI or are we preparing for the next NEET MDS paper? I'm asking you this because those of you who are interns, बच्चे target the NEET PG paper in a better format. I'm saying so because give proper time to each subject. 2 revisions are a minimum. See, normally when we hear topper interviews and all, toppers are totally divided. Firstly, they say कि some of them have done 4 to 5 revisions. Some of them have stuck to 2-3 revisions. But 2 good revisions, personally, I feel is sufficient. Provided you have not missed out on topics and you have done them in a proper manner with a focused strategy and with MCQs along with it. For the interns especially, बच्चे INI will be slightly tougher. It is mostly targeted by post interns. Even if the interns are eligible, please target NEET PG exam. And it under no circumstances mean that it is not possible to clear the paper during internship. I don't believe in that at all. So Mitra, नहीं ना, थर्ड वन नहीं, अक्षिता सेकंड, ठीक है. स्टडिंग बट नहीं, डायरेक्शनलेस नहीं सोचना है यार. देख, योर अक्षिता, योर आंसर्स वर गुड. आई एम कंफर्टेबल विद योर आंसर्स एंड आई एम से, यू नो, आई मीन यू हैव अटेंडेड माय क्लासेस, यू नो आई एम वेरी ब्लंट. सो आई विल नॉट से दैट यू आर डायरेक्शनलेस. डू नॉट इवन think of it in that way. To the crash course part, I am saying so because crash course, all the subjects have been concised to 1/5 of the original class. Suppose even in dental, bigger subjects, prostho, endo, medicine, surgery, oral surgery, these are big huge subjects, 25 to 26 hours or even 30 hours full course, but they have been concised maximum to 6 hours in crash course. Follow it up with test and discussion. T&D, test and discussion, is 3 hours. So these 5 to 8 hours, I'm not even talking of path and micro. Path micro, I've wrapped it up in 4.5 hours, sufficient. I've gone faster in it. But if you do the crash course and test and discussion, give the test and listen to the discussion, these 7 to 8 hours of study will be extremely beneficial for INI. But I'm again saying this with a huge but. Do not do this if you have not done minimum of 2 revisions till now. Do not think that this will form a substitute for the full class. नहीं, समझ में नहीं आएगा, will not be able to understand it. Do the crash course in T&D only after you have read all 19 subjects and you are done with 2 revisions, because it serves as the most important topics. We cannot go and give the paper just on the basis of crash course and T&D. There is no doubt about it. Firstly. Secondly, for the interns, अपने में से कितने interns हैं अभी? How many of us are interns? संगमित्र बच्चे टेंशन नहीं लेनी है. देखो, टाइम तो रहेगा ही. I know that during internship you go to college in morning and come back and it is tough. But recent out of top 10 ranks, 2 to 3 ranks have always been interns, and especially last year we had 5 interns in top 10. I'm not even saying we have to target top 10, top 20, not at all. That is vulgar ranks, yeah. I have never cleared, I have never topped in any paper. Yes, I am from the top 3 colleges in India, purely on basis of good luck, doing good things in life, and some hard work. I say it very frankly. So do good things. Tanvi bache, always welcome, always welcome. But if you're an intern, the amount of time that you have is okay. After coming back, freshen up, have some snacks, start studying, put in about 3 to 4 hours of focused study time, maintain a good personal life, social life, personal life, academic life balance, because there's no way we can study all the time. I mean, no doubt about it. I'm saying this very frankly. I had a major fight with one of my very close friends recently, and I was supposed to record the crash course and stuff. It got massively delayed because I had not wanted to do a half-hearted approach. अगर personal life में गड़बड़ है, देखो as such we do not have much personal life, but अगर personal life में गड़बड़ है तो academic life अपनी थोड़ी सी गड़बड़ होगी. So maintain a good personal life, academic life balance, and things will certainly work out better than we expect. Next point. So I actually wanted to talk with you guys with respect to this. So coming back, let us quickly have a look at 3-4 more topics before we wrap up our session. Arachidonic acid metabolites, which are again important. There are 2 main pathways, COX and LOX, cyclooxygenase pathway and lipoxygenase pathway. Cyclooxygenase pathway is responsible for formation of 3 metabolites, that is prostaglandins, PGD2E2, prostacyclins, and thromboxanes. Thromboxane, the name tells you, it is responsible for thrombus formation. It forms thrombus. So it is responsible for vasoconstriction. It causes vasoconstriction and increases platelet aggregation. That is how thrombus will form. It causes vasoconstriction and increases platelet aggregation. Thromboxanes. Versus prostaglandins and prostacyclins, which they have an opposite role. They cause vasodilation. And reduce platelet aggregation. Last time's NEET PG question, MBBS segment. Vasodilation and reduced platelet aggregation is associated with prostaglandin, prostacyclin, thromboxane, both A and B. This was cyclooxygenase pathway or COX. Cyclooxygenase pathway. Versus the next is LOX, lipooxygenase pathway, which is responsible for formation of 3 metabolites again. Leukotriene B4, which you already know is the most potent chemotactic agent. Leukotriene C4D4E4, which play a role in asthma. Asthma is bronchoconstriction with increased mucus secretion. It plays a role in asthma. And the most important, lipoxins, which are anti-inflammatory in nature. Lipoxins, which are anti-inflammatory. Very, very important. There are only 3 anti-inflammatory mediators, which are interleukin 10, TGF-beta, transforming growth factor beta, TGF-beta, and lipoxins. You have to know this. These are the only 3 anti-inflammatory mediators: interleukin 10, TGF-beta, and lipoxins. Whereas both pro and anti-inflammatory are interleukin 4 and interleukin 6. An important slide. So let us have a look at cytokines here only. We saw the first acute inflammatory mediator, that is arachidonic acid metabolites, 2 main pathways, COX and LOX, cyclooxygenase pathway and lipooxygenase pathway, COX and LOX. Next are the cytokines. We can divide cytokines into acute versus chronic. Acute cytokines, they will cause fever, sepsis, interleukin 1-6 fever, interleukin 8 ARDS, TNF alpha sepsis. It is responsible for sepsis. You know that. These are the acute cytokines. Which is the main cell of acute inflammation? Neutrophil. So acute cytokines, they play a role in neutrophil activation. Versus chronic cytokines, I want you to tell me, they are associated with which hypersensitivity reaction? Main cell, macrophages. So they play a role in macrophage activation. Chronic cytokines cause macrophage activation. Cell of acute inflammation, neutrophil, chronic macrophage. Which hypersensitivity? You know well there are 4 types of hypersensitivity, 1, 2, 3, 4. One is asthma allergy, immediate type. 2, antibody mediated. 3, antigen antibody immune complex. 4, cell mediated or delayed type. So chronic inflammation, chronic hai na bache? So it is associated with type 4 hypersensitivity. That is cell mediated or delayed type. Cell mediated or delayed type of hypersensitivity. It is chronic inflammation, so it is associated with delayed type of hypersensitivity. Main cell macrophages. Main cytokines, perfect. Main cytokines being interleukin 2, interleukin 12 and interferon gamma. So 3 options. See, have a look. TNF alpha plays a role in sepsis. TGF beta, transforming growth factor beta. TGF beta is anti-inflammatory in nature, whereas interferon gamma is a chronic cytokine. Interferon gamma, chronic cytokine. So chronic cytokines being interleukin 2, 12 and interferon gamma. This was with respect to cytokines. You again usually get a question on cytokines. And this gets us to our last main topic that I want to discuss for our INI segment. That is, let us have a look at the genetics, the images part. So starting with our first image. Starting with the first image, what do we see here? You're sitting in the OPD. A child presents to OPD with mental retardation, abundant neck skin. I want you to tell me the diagnosis, which is radiologically seen as increased nuchal fold thickness. Radiologically, it is seen as increased nuchal fold thickness, abundant neck skin, epicanthic folds with a flat facial profile, that is face chipta hua hai, flat facial profile, and a single transverse simian crease. We have multiple lines now. Single transverse simian crease. Out of these, above 3, 4, 5 points, 3, 4 are given in the question. This is a case of Down syndrome. This is a case of Down syndrome, that is trisomy 21. Downs, that is trisomy 21. Trisomy 18, Edwards syndrome. 13, T for 13 na Patau's. Patau's has a T in it. Patau's. Hansika bang on right here. Agreed. Nidhi agreed. Downs. So questions are asked on which is the most common CVS abnormality seen in Downs. So let's have a look at the questions. Most common CVS abnormality. Shilpa agreed. Most common CVS abnormality in Downs being endocardial cushion defects. They will give the upper 3, 4 points in the history. It will be history based question and question will be asked from the lower 5, 6 points. Most common CVS abnormality being endocardial cushion defects, followed by VSD, ventricular septal defects, followed by ASD. It is associated with congenital heart defects in about 40% cases. Intestinal stenosis. Intestinal stenosis at duodenum. Most common site being duodenum. Increased gap between first and the second toe. That is called as saddle toe deformity. Increased gap between first and the second toe. That is called as saddle toe deformity. Hypotonia. The tone of muscles is reduced. Umbilical hernia. But please note, umbilical hernia is a feature of Down syndrome, not Turner syndrome. Recent PYQ, it is a feature of Downs, not Turner's. And increased risk of leukemias. So there are 2 questions which I want you to tell me. Most common leukemia with Downs. Most common leukemia associated with Down syndrome. And most common AML with Downs. So firstly, most common leukemia with Downs being Down syndrome occurs in children now. So most common leukemia in Downs being ALL. Which is the most common leukemia seen in children? ALL, acute lymphoblastic leukemia, ALL. AML is divided into M0 to M7. Overall, least common AML is AML M7, the last digit. But It is the most common AML in Downs, AML M7, also called as acute megakaryocytic leukemia. Also called as acute megakaryocytic leukemia. These are the questions that we get from Downs. Most common leukemia in Downs, ALL. Downs is seen in children, most common leukemia in children, ALL. But most common AML in Downs being AML M7, megakaryocytic leukemia. Next, agreed. Now have a look at this image. I want to discuss 3 images before we wrap up our today's session. Guys, I am pretty sure we guys are much more enthusiastic about this. I just told you that she is a 16-year female. Diagnosis. What do we see here? She has, the minute I see this image, she has a short stature, low webbed neck, widely spaced nipples, streak ovaries. That means there is fibrosis in her ovary. Streak ovaries. So it is associated with primary amenorrhea. The girl has never bled. Streak ovaries or primary amenorrhea. Cubitus valgus. Valgus means the elbow is out. Cubitus valgus. Varus is inside. Making this as turnus. हाँ ना, बच्चे अच्छे से आ जाएंगे, तुम चिंता नहीं करो. Last 2 images, plus this is one of my favorite images. So Hansika Akshita agreed. Turnus. Tell me 2-3 questions about turnus. My first question is IQ. Nidhi agreed, बच्चे. Tell me 2-3 questions. IQ, you very well know turnus is 45 XO. IQ, low, normal, high. Next question, FSH and LH, low, normal, high. Third, Turner syndrome, but this is a fact that it is not associated with malignancies. Down syndrome was associated with malignancies, not Turner's. So let's start with IQ. Low, normal, high. Very right. See, we know this na, ki more the number of X chromosomes, lower is the IQ. I guess I keep on saying shit like this, that is why I'm single. But IQ, normal. This is 45 X, so 1 X chromosome is less. This does not mean IQ is high, IQ normal. FSH and LH, low, normal, high. FSH and LH high. Why? Because the hypothalamic pituitary axis is trying to stimulate the ovaries. So FSH and LH is high. Turnus. Perfect. Whereas now have a look at this image, our last image for today's session. The minute I see this, I know he's a male because he has a penis with small testis, atrophic testis. The male secondary sexual characteristics are absent. Frontal baldness is absent, fewer chest hair, gynecomastia, female type pubic hair, unicoid body habitus, that is narrow shoulders with broad hips, which this is called as unicoid. This is called as unicoid body habitus. This is the female body portion, narrow shoulders with broad hips. Unicoid body habitus, making this as a case of Klinefelter syndrome. So again, recent PYQ, you were given a history-based question. A couple is trying to conceive for the past 6 years. On examination, the female is normal, but the male has gynecomastia, atrophic testis, and female type pubic hair distribution. Diagnosis, Klinefelters. Most common Klinefelters being 47 XXY. This is low IQ. And in this also, FSH and LH is increased. First class. Totally agreed. This was Klinefelters. Done. Totally done. So I guess sufficient for today. No doubt about this. We have had a good session, but we'll of course be meeting for the full class very soon on our DBMCI app. No doubt about this. But bestest of luck from bottom of my heart. Yeah, you guys are good. Few of my closest friends are in the dental segment, and I know this, that you work hard. You work extremely hard. You are focused. You are dedicated. Keep on slogging, and the success shall be yours. Do not give up. In case you have any queries whatsoever, you can send me a personal WhatsApp, or you can DM me on Telegram, and 100% I'll take care of it. Thank you guys. Have well-deserved dinner. I know many of you would not even have taken dinner till now. So have dinner and see you all real soon. Thank you. Thank you and take care.